I like to call the knee the redheaded stepchild of the hip and the foot, because
Yeah.
the hip influences the knee and the foot influences the knee, and the knee just takes the brunt of the issues if there are issues. And so I always have my patients take their shoes off when I'm seeing somebody for a knee. I
Okay.
want to, number one, take a look at, are they ultra flat? Are they ultra high arches? And make sure that we kind of at least address that. What do I see most commonly with my runners? IT band syndrome, again, is something that a lot of patients present with, that outside the knee pain, right? Patellar tendonitis. I will see that in some
Yep.
of my patients. That's more of it. So outside the knee, right? So if we're, we're talking here, you and I are talking, we can go through this all day, but I try to talk a little bit more on the lay side to kind of make sure people understand. So
Absolutely.
So when I look at the knee, again, I look at the knee kind of like I look at the hip. If it's on the outside of the knee and it's a runner, I'm looking more at that IT band, where that Gertie's tubercle. Um, Uncommonly, but something that I do see is popliteus gets locked up, and
Yep.
popliteal tendonitis. That's something that not a lot of people have much experience with, and that can be something that really knocks somebody out, and they just can't do anything. And
Yeah.
then I'll kind of look at, is it in the front of the knee, right? Anterior for us. Is it in the front of the knee? Is it in that patellar tendon? Is it below the kneecap? If it's
Yep.
below the kneecap, a lot of times I'm thinking more of a tendonitis. If
Yep.
it's above the kneecap, I'm thinking more of quadriceps. If it feels unstable, I'm thinking more of, is there some sort of ligamentous, MCL, that kind of thing. So that's kind of how and then on the inside of the knee, I mean, and I'm not hitting kind of the most commons. Some of the most commons you see are meniscus injuries, right? And so
Yeah.
I would say that, if usually depends on, again, the body structure. Somebody's a little more bow-legged, right? They're gonna predispose themselves to more that medial wear pattern. The more knock-kneed, you sometimes see a little bit more of the outside the knee wear patterns. And so based on all that, it's a lot to digest, a lot to think about. But let's talk about most common. So most common, I'd see somebody for IT band syndrome, and
Yeah.
I think
Patellar.
that, yeah, and I think that your team does fantastic with that. I don't see as many of those as I bet that you see. So one of the reasons, and I'm going to pull up this screen. Let me pull up the screen now to you 1 second. I think this is a pretty good screen too. So I want somebody to really utilize conservative care first, right? I want them to have, we, there's, I always tell patients when they come in, we can do nothing today. There's no reason for us to do anything when you come in. A consult, if you're coming to RunFest, we put a consult built in if we don't take your insurance, for any of the participants in RunFest to come see us. We want to bring people in, give them a 60-minute evaluation with ultrasound to make sure that we're really truly diagnosing the root cause of the problem, not just taking care of something and put a band-aid on it. And so one of the biggest things that I would say, so that's a big difference in us, and making sure that we see you and do the right thing. I'm sorry, I lost my train of thought for a second. Your question about, going from you, or so conservative care. So conservative care first, okay,
Yeah.
and that's really working with a quality PT. Not everyone is a quality physical therapist, a quality chiropractor. I like to call the people that are really good physios. I think it's a European term. They call them physios. They're doing hands-on work. They're getting in there, spending an hour with their patients. And if those physios aren't moving the needle, where you're not feeling that you're getting better, that's when you need to seek something more interventional. Whether it's, I know you do dry needling, Lisa. You do cupping, you do newbie. So a lot of times when you see a good physio, all these things are being really utilized. That's quality conservative care. And so once that quality conservative care is 6 weeks, I think that, Lisa, would you say give you 6 weeks and see how things go? What's your time frame? When do you feel like when you go to the next step? So cortisone in general is toxic to the body, and the doses that we're giving to patients are extremely toxic. We could do 400 nanogram dose, and that's actually chondroprotective, but we're giving 10 milligrams or 40 milligrams of Kenalog, which is exponentially higher. I like to quote Chris Centeno, who's the chief medical officer for Regenix. Why? Because he's been doing this for 20 plus years now at this point, and the doses that we give are the size of the Empire State Building. And the ones that really need to make a change, all you need is the size of a pen. So we're giving too high of doses, which then cause toxicity to cartilage, toxicity to tendons, osteoporosis. It suppresses the immune system. There are systemic effects. If people get a steroid injection, their blood sugar will go up if they're diabetic or pre-diabetic, and then it accelerates arthritis. And again, I'll share a slide just because I have it right in front of me and I was reading off it most of the time. But pros and cons of not only epidural steroid injections but steroid injections in general. Really, the pros are anti-inflammatory. They are a short-term solution. In some cases, they are a pretty good solution, and that would be more of treating bursitis and inflammation in the bursas without any kind of concomitant or issues with tissues, right? So if they don't have corresponding tears with the bursitis, that would be a reason for steroid, right? If you can get the bursitis to go away, that's great. These are really the pros and cons of steroids. And just because something is covered by insurance doesn't mean it's the best for the patient. We're seeing that more and more. And that's really my biggest pet peeve is that, oh, well, it's covered by insurance, so I'm just going to do it. Well, we're better than that, and we need to be better clinicians for our patients, because if I know for a fact that 1 in 10 patients get spontaneous osteonecrosis from a steroid injection to the knee. So do you
Yeah.
want that for your patient? I mean, is that what you want for mom or dad? I always treat my patients like I treat my mother or father, and I've treated my mother and father. So it's one of those things that we have to be better clinicians. We have to be better evidence-based stewards. We're supposed to be lifetime learners. I've got 2 med students in my office right now, and we need to continue to learn to get better as we go along.
I'm a firm believer motion is lotion, and I
Yep.
want patients to be as active as possible in my recovery period. And one of the things that I see is that we tell patients as long as they're not having 2 out of 10 pain or greater. So say you've got a little bit of chondromalacia, you flared up the cartilage behind your patella, and you got some synovitis, and that's something I do see a lot of patients and runners with. And so what I would tell a patient is for 48 to 72 hours post-procedure, you're gonna have some pain and swelling. After the pain and swelling, you get back to your baseline about 3 to 5 days later. And what I tell patients at that point is I have a protocol that I give to going back to my quality therapy, before and after. Conservative care is there, and you want to work with strengthening the hips, strengthening whatever's finding the weakness that's causing the issue, because there's usually something causing this injury to happen.
Yes.
And so work with that therapist when you can, if running is what you want to do. I would start by, babies crawl first, then they walk, then they run, right? Same thing here. We want you to work on getting those muscles and everything stabilized. And then you go and start working, running, and then, that kind of thing. Now, if you're having too much pain, you can go 250 meters, then you have to stop, walk, that's fine. I think that's totally appropriate.